Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium. Thank you.
Good morning. My name is Dr. Alex Wong, and thank you for tuning in to this LE&RN live stream. I am an associate professor at the University of Southern California, a plastic and reconstructive microsurgeon, and director of a research laboratory that studies basic and translational aspects of lymphedema. Thank you for tuning into this live stream. I hope to hear about your questions and engage in a lively discussion at the conclusion. I'm going to assume you're familiar with lymphedema. However, formally, it is defined as the abnormal accumulation of interstitial lymph fluid and fibroadipose tissue. It commonly results after injury or infection of the lymphatic system. However, there are congenital abnormalities that result in lymphedema as well. It affects over 200 million people worldwide, and in the United States, it's due mostly to secondary lymphedema and amounts to affecting approximately 3 million people. The lymphatic system is unique in that it is part of both the circulatory and immune systems. Its function is to return excess capillary filtrate to the circulation. It filters bacteria. It's involved in immune cell trafficking and also the transportation of dietary lipids. Secondary lymphedema exists in multiple forms. However, the most commonly seen is that associated with breast cancer. The incidence rate is approximately 40%. It affects 17% of breast cancer survivors, develops within 2 years, and has the risk factors indicated below. It's important to note that lymphedema can occur on other parts of the body and are related to cancers other than breast cancer. Specifically, they can occur after the management of genitourinary cancers such as bladder, penile, and prostate, gynecologic cancers including cervical, endometrial, and vulvar cancer, head and neck cancer, soft tissue sarcoma, and melanoma. Essentially, any cancer where the lymph nodes need to be managed as part of the cancer treatment put a patient at risk for lymphedema. The incidence of lymphedema after these different cancer types is quite varied. They can be as low as 1 or 2% or as high as 70 to 80% depending on the study. The spectrum of the clinical phenotype of lymphatic disease is wide, and this is due in large part to the fact that the different cancer types require different lymphatic dissections, and therefore the pattern of injury is variable. You can see here in the picture the different stages of clinical lymphedema, starting from stage 0 or normal going to stage 3, which is an abnormal irreversible phenotype with sclerotic lymphatic vessels. I also think that the response to lymphedema is variable and depends on the host. And despite doing the same kind of lymphatic injury to a series of different patients, you might see, and in fact do see, different manifestations of this. And this in part explains the diversity and spectrum of secondary lymphedema. The variable nature of clinical lymphedema after lymphatic injury is in part explained by the fact that the pathophysiology is complex and multifactorial. For example, at the top of the slide, after lymphatic injury, this leads to a backflow or lymphatic fluid stasis. In general, this leads to lymphedema if you have paralysis of the lymphatic fluid, ectasia of the lymphatics, muscular dysfunction, valvular incompetence, and this progresses to lymphatic intimal hyperplasia. This proceeds to lymphedema if you do not escape this phenomenon. The way to escape this would be on the far right of the slide, where you can drive sufficient lymphangiogenesis in response to lymphatic injury. You go towards the upper portion of the slide and don't get disease if you can create enough lymphatic conduits to not have lymphatic fluid stasis. If you cannot drive enough lymphangiogenesis as a response, you progress to clinical lymphedema. At the red portion of the slide where it says inflammation, this also is a very important part of regulating the response to lymphatic injury, and it's been shown by several groups that inflammation is critical to the development of the phenotype, and therefore this would be another place where the variability of the disease could be controlled. While that last slide was a little bit busy, this one is simplified to drive home the important concepts that will be important to understanding some of the subsequent slides. Essentially, there are two responses to lymphatic injury. The first would be highlighted in the upper left-hand corner, compensatory lymphangiogenesis. If this happens, there's no disease. The other possibility is that the body does not drive sufficient lymphangiogenesis, and this results in progression to lymphedema. Once lymphedema develops as a disease, it is very difficult to treat. I'm not going to discuss treatment options, but in general, they fall into non-surgical and surgical treatments as listed here in the left-hand table. The benefits of treatments include symptomatic relief, slowing disease progression, improving symptoms, reducing limb size, and improving quality of life. However, there is no cure to lymphedema, and therefore I think our best opportunity to helping people is to actually try to do things to prevent it from developing in the first place. We feel that the best opportunity to make an impact on this disease is to really prevent it from happening in the first place. And therefore, my research group aims to study and understand the response to lymphatic injury. And by examining this, we look at the situation after lymphatics are injured, and then hypothesize that we can potentiate and accelerate lymphangiogenesis with growth factors that are specific for lymphatic endothelial cells. Another opportunity would be to study and figure out ways to block the lipogenesis and fibrosis that happens as a result of the uncontrolled inflammation after lymphatic injury, and therefore targeting or inhibiting pathologic inflammation would be also another significant opportunity to prevent lymphedema. My group focuses on the former strategy, which is to identify lymphatic growth factors that can help stimulate new lymphatic vessel growth after lymphatic injury. So what would be ideal characteristics for this kind of growth factor? Well, first, it would have to be non-toxic. It would need to be biocompatible or biodegradable. It would need to have no side or off-target effects and be specific for lymphatic endothelium. It should be efficiently distributed to the site of lymphatic injury. It should have consistent action. It should be easily and predictably metabolized or eliminated, and it should be relatively inexpensive. So what are some of the pro-lymphangiogeneic growth factors? If you look at lymphatic cell biology, research has described several candidates, and starting from left to right, you have the angiopoietins, the vascular endothelial growth factors, or VEGFs, the FGF family, or the fibroblast growth factors, hepatocyte growth factor, or HGF, platelet-derived growth factor, IGF-1 and 2, as well as adrenomodulin. All of these can drive lymphangiogenesis. We can quickly eliminate the growth factors on the right that have the X on top of them because these are not specific for lymphangiogenesis and also drive growth, proliferation, and differentiation of non-lymphatic cell types. The next two groups, which are suboptimal, include the angiopoietins and VEGF-A because they not only drive lymphangiogenesis but also regular blood vessel growth and therefore are not optimal for this application. That leaves us with the most studied lymphatic-specific growth factor, and that's VEGF-C, initially described in 1997 in Science. Since then, there have been over 2,800 citations in the literature. VEGF-C binds to VEGF receptor 3 and VEGF receptor 2. The lymphatic-specific behavior is driven by VEGF receptor 3, which is seen on the far right. VEGF-C is an interesting molecule. Due to its very specific pro-lymphangiogenic effects, several groups have investigated it with encouraging data. In 2002, Saristo and others showed that using gene therapy vectors, you could deliver VEGF-C and drive lymphangiogenesis specifically with minimal blood vessel side effects. In 2003, Yoon et al. Used different kinds of gene therapy vectors, but showed that it also augmented lymphangiogenesis specifically and also could ameliorate secondary or surgically induced lymphedema. Data from the early rodent studies were confirmed in larger animals and were equally encouraging. Several groups investigated lymph node transfer in combination with administration of VEGF-C and demonstrated it had promise for the treatment of lymphedema. Additionally, groups tested the different isoforms and provided higher resolution as to which form of this molecule could be a good candidate for further therapeutic development in humans. Data from the rodent studies were confirmed in larger animals, further stimulating interest in VEGF-C. Groups demonstrated that lymph node transfer in combination with administration of the VEGF-C growth factor was effective in large animal studies for lymphedema. Furthermore, the isoforms were carefully dissected, and specific forms of VEGF-C were found to be very promising in large animals. The many studies which confirm that VEGF-C has a role in lymphangiogenesis is very promising. So promising that one of the earlier pioneers in VEGF-C research started a company to develop a clinical modality for the treatment of lymphedema called Lymphactin. This is being developed by a company called Herantis. Lymphactin is an early-stage pharmaceutical agent which is essentially VEGF-C gene therapy, and the thought is that this can be injected at sites of lymphatic injury and can be used to stimulate lymphangiogenesis and establish a functional lymphatic network in the context of surgically induced secondary lymphedema. The hope is that it could be an additional modality to prevent or treat this disease. Based on publicly available information from Herantis, the company that makes Lymphactin, they've demonstrated that a phase 1 open-label study to assess safety, tolerability, and preliminary efficacy of Lymphactin, or VEGF-C adenovirus, is tolerated in patients with secondary lymphedema due to breast cancer. Their press release from April of 2018 indicated that all of their recruited patients tolerated Lymphactin, and it has been safe with no dose-limiting toxicity. This encouraging data has allowed them to initiate a phase 2 clinical study. While the results of the Lymphactin VEGF-C gene therapy trial are promising and intriguing, I think it's important to note that VEGF gene therapy may have potential risks. In fact, in 2001 in Nature Medicine, a group demonstrated that VEGF-C could promote cancer metastasis by inducing tumor lymphangiogenesis. Unfortunately, patients that have secondary lymphedema usually have had tumors in the past, and by exposing them to high amounts of VEGF-C, this poses potential risks. While VEGF-C is a very efficient driver of lymphangiogenesis and the clinical trial data from Lymphactin is very encouraging, my group was interested in identifying some potential safe alternatives to investigate. Essentially, we didn't want to put all of our eggs in one basket, and therefore we performed a search for some alternative pro-lymphangiogenic drugs or pathways. At the bottom of the screen, you see VEGF-C highlighted in blue, and while that it's a major important aspect of lymphatic differentiation, all the items and genes listed in black are other very important control points for lymphangiogenesis, and therefore represent good opportunities in addition to VEGF-C. The way we approached this was to conduct an efficient in vitro screen for different compounds that had pro-lymphangiogenic effect on lymphatic endothelial cells in vitro or in tissue culture. Our finding most significant was that retinoic acids were very efficient at doing this, and in panel A you can see that several of the different retinoic acids, from 9-cis-retinoic acid to all-trans retinoic acid, were good at driving lymphatic proliferation. On the right, we specifically investigated 9-cis-retinoic acid because we found that it was dose-dependent on driving proliferation of lymphatics. In 2012, a collaborative effort between my group and Young-Kwan Hong's group at USC led to the demonstration that 9-cis-retinoic acid could promote lymphangiogenesis and enhance lymphatic vessels regeneration in small animals, thus implicating this as a potential therapy for secondary lymphedema. So what is 9-cis-retinoic acid? It's a metabolite of vitamin A. It's required for the development of chordate animals and involved in axial pattern signaling. And the fortunate thing, and a reason that we have an interest in investigating it further, is that it's already FDA approved for 2 indications, including Kaposi sarcoma skin lesions and severe chronic hand eczema. Therefore, given its safety in humans, we believe that this is potentially interesting as a drug that can be repurposed for the treatment or prevention of lymphedema. So what are the details on how 9-cis-retinoic acid works? Here I'll show some data about lymphatic endothelial cell migration. You see on the left side of the slide some dashed lines. These are gaps created by a scratch, essentially an in vitro wound. And on the far left column, this is what happens after 24 hours in the control situation where there's no drug. And you can see that after 24 hours, there's still a gap between the dashed lines. When you treat with 9-cis-retinoic acid, these dashed lines meet together and there's no gap, indicating that the lymphatic endothelial cells migrate significantly faster when they're given the drug. And we showed that 9-cis-retinoic acid promotes in vitro lymphangiogenesis using a tube formation assay. On the far left, you see lymphatics in matrigel showing a cobblestone appearance, which is normal for lymphangiogenesis. When they're treated with 9-cis-retinoic acid, in the middle, you can see that the density of the cobblestoning is much higher, indicating that the drug is stimulating more in vitro lymphangiogenesis. When you load a matrigel plug with 9-cis-retinoic acid drug and then implant it into an animal, you can see that it induces robust lymphangiogenesis in the animal, as indicated by the characteristic lymphatic sprouting seen in the right and not seen on the left when there's no drug. In 2016, our group took this one step further and developed a very clinically relevant rodent hind limb model and asked the question, does 9-cis-retinoic acid work to prevent this? And in fact, it did. This was our rodent model, which consisted of complete lymphatic removal followed by a circumferential skin excision to ablate both the superficial and deep lymphatics. In the bottom left corner, you can see a normal mouse paw. On the far bottom right, you can see the results of lymphadenectomy, leading to lymphedema of the rodent paw, and a very significant and measurable difference. With this robust and clinically relevant rodent paw lymphedema model developed in our laboratory, we used this to test whether 9-cis-retinoic acid could prevent or alter the course of lymphedema development. So on the left-hand side, you see the process of lymphatic swelling that occurs after 10, 20, 30, and 40 days after lymphatic ablation, and you can see that this is a lymphedema phenotype and not just edema, because the lymphedema persists for a very long time. To the right, adjacent to that, you see animals that were treated with 9-cis-retinoic acid at the time of surgery, and at all time points, 10, 20, 30, and 40 days after lymphatic injury, you can see that there is significantly less paw swelling and thickness, indicating that this lymphedema was significantly prevented. This is a graphical representation of our data in which the red marks are the percent change in the paw thickness in the control animals that had lymphatic injury but no drug treatment. The green data points are the animals that had 9-cis-retinoic acid and therefore have very little percent change in paw thickness. In panel A, you can see a scatter plot, and in panel B, we plotted the percent change over time. Of note, you can see 2 phases after the surgical injury. The early phase of edema goes up till about 15 days, and then after 15 days, the swelling is chronic, and you can see the animals that did not receive drug have a persistent thickness of their paw, whereas those that were treated continue to go down and become slimmer, indicating that they do not develop clinical lymphedema. Our laboratory developed and utilized transgenically modified animals that express green fluorescent protein under the control of the PROX1 promoter, which is specific for lymphatic endothelium. Using this animal, we asked whether 9-cis-retinoic acid could increase lymphangiogenesis, and we found that it does. On the left-hand corner, you see that this is the baseline lymphatic structures that you would see in the dermis of skin. On the right upper-hand corner, this is the response to dermal lymphatics after 9-cis-retinoic acid treatment. You can see that the overall density of lymphatics is higher, the total length is longer, and also the branching index is significantly higher, thus indicating that 9-cis-retinoic acid is certainly associated with more robust lymphangiogenesis. Some of you might be wondering, so how does 9-cis-retinoic acid work? What is its mechanism? So we addressed this by looking in vitro at lymphatic endothelial cells and ultimately found that when you expose these cells to 9-cis-retinoic acid, it regulates cell cycle inhibitors, specifically P27 and P57, and also downregulates fibroblast growth factor receptor 3 specifically. Although work is ongoing, we believe that these are critical aspects of how 9-cis-retinoic acid can help lymphatic endothelial cells drive lymphangiogenesis, both in the tissue culture dish as well as in vivo. In January of 2019, my group published this paper that further delineated and confirmed that fibroblast growth factor receptor 3 signaling is important for how 9-cis works. We wanted to better understand the dynamics of fibroblast growth factor receptor 3 upregulation in response to 9-cis-retinoic acid. And on the left, you can see a quantitative RT-PCR that indicates sharp upregulation of FGFR3 at 6 hours after treatment with 9-cis-retinoic acid, and then it goes back down pretty sharply. On the right, we used a short peptide that specifically blocks FGFR3 signaling and found that this could be useful for further in vivo studies. After verifying that this short peptide called P3, which was specific for FGFR3 inhibition, worked in vitro, we then did some in vivo experiments. On the right, you can see tracheal lymphangiogenesis assays, and basically at the middle of the tracheal ring, if there's lymphangiogenesis, you will see sprouting lymphatics. Starting from the top, the vehicle control does not induce much lymphatics, and if you look on the far right column, there's not much sprouting between the dotted lines. Going down the column to the second row, if you give 9-cis-retinoic acid, you can see, as indicated by the white arrows, some lymphatic sprouting in the middle. If you give 9-cis-retinoic acid plus a scramble or inactive peptide, you see similar sprouting. However, if you give 9-cis-retinoic acid in combination with the VEGF-R3 specific inhibitor called P3, you now don't see the 9-cis-retinoic acid induced sprouting, specifically indicating that it really is this FGFR3 signaling that's important for how 9-cis-retinoic acid works. We were interested in whether 9-cis-retinoic acid's effect was dose-dependent, and we tested that in the following manner. These are tail lymphedema assays, and you can see on the left-hand column the baseline at day 0 and at day 42, or 6 weeks later, the result after both deep and superficial lymphatic injury. In the first row, you can see animals treated with a vehicle control, basically no drug, and at 6 weeks on the far right column, you can see the characteristic lymphodematous tail swelling. In the second row, if you give 9-cis-retinoic acid for only 7 days, it does lead to some improvement, but you can still see evidence of lymphatic swelling as indicated by the orange arrow. If you give it for longer, for 14 days, in the third row, you can see there's improved essentially prevention of lymphedema or less lymphedema at day 42. And if you give it for 45 days, then you basically see very little lymphodematous change and essentially full prevention of the lymphedema phenotype after lymphatic injury. The last row called delay is one where we waited a week before we started the 9-cis-retinoic acid, and you can see that if you don't give it immediately, it's not quite as effective, thereby indicating, at least from my thought, that it sort of needs to be given early so that you can induce enough lymphangiogenesis so that the obstructed lymphatic fluid can quickly find an exit and therefore not result in long-term sustained lymphedema. This is a bar graph representation of the tail assays that I showed in the previous slide, just indicating that the differences between these different durations is statistically significant from each. And again, dose dependency is indicated by the fact that the more 9-cis-retinoic acid that's administered, the better things work, and also this leads to more robust lymphangiogenesis as measured by lymphatic density on the y-axis. To recap, I've addressed two established pro-lymphangiogeneic drugs that potentially might be useful for mitigation of lymphedema clinically. On the left, I started with VEGF-C, which is very potent for lymphangiogenesis, very well studied in the literature. However, its drawback is that it may have a possible negative effect in the context of post-oncologic cancer patients. It also may be expensive to make given current efforts to use viral vectors for VEGF-C gene therapy. On the right, I've listed some aspects related to 9-cis-retinoic acid, which I've studied in my laboratory. This is not a growth factor, and it actually promotes differentiation, and therefore it's different from VEGF-C. It is potentially much more safe in the post-oncologic setting. Since it's not a growth factor, it doesn't drive stimulation of proliferation. It really stimulates differentiation. We have good insight into its mechanism, and it's getting better. It's an FDA-approved molecule, whereas VEGF-C is not, and it's effective at disease prevention in our rodent models. What are some future studies for this? We are giving it systemically in our animal models. The question would be, if you can give this topically, would this be safer and also effective? Does it have an effect on established disease? Meaning if you have lymphedema that's been there for several weeks, could 9-cis-retinoic acid help? I'm not sure if it does. I think in general it has more of a role in prevention of lymphedema. However, to address these more systematically, we'll need to do some large animal studies and potentially human clinical trials. Since we are ultimately interested in bringing 9-cis-retinoic acid to help patients with lymphedema, these are some of our ongoing studies. The first is to further investigate its drug delivery. We're looking at oral versus IV versus sustained released pellets that can be placed at the site of lymphadenectomy and be depot release agents. We're also looking at large animal studies so that we can prove that 9-cis-retinoic acid works in a second non-rodent species, and this is important for FDA approval for this indication. And lastly, we're going to look at whether or not 9-cis-retinoic acid can be used in established lymphedema. Since much of our data indicates that some sort of surgical trauma is necessary for 9-cis-retinoic acid to induce lymphangiogenesis, I believe that alone it may not be that useful. However, since surgical procedures such as vascularized lymph node transfer are being offered to patients with clinical disease, I believe that 9-cis-retinoic acid may be a good adjuvant to further improve potential benefit with these physiologic lymphatic surgeries. So what are the fruits of some of these basic and translational scientific investigations? Basically, by studying and understanding the response to lymphatic injury, this may open some therapeutic doors to improving treatment and potentially prevention for patients at risk for lymphedema. By studying lymphatic injury and also agents that can accelerate lymphangiogenesis in the context of lymphatic injury, I believe we have some factors including VEGF-C as well as 9-cis-retinoic acid that may be useful. Although I've focused on using pro-lymphangiogenic factors to overcome lymphatic injury, Another important aspect of the pathophysiology after lymphatic injury is the uncontrolled inflammation that can lead to lipogenesis and fibrosis, which are important phenotypes of lymphedema. Targeting this pathologic inflammation certainly is also another excellent strategy that could be used on its own or synergistically with the pro-lymphangiogeneic compounds I talked about. In the interest of time, and also because my laboratory is not expert in the inflammatory manifestations after lymphatic injury, I highlight some of the work of some of my colleagues, including Stan Roxon at Stanford and Babak Marara at Memorial Sloan Kettering Cancer Center. Both of these groups have looked at the role of inflammation after lymphatic injury and also have identified specific mechanisms of how inflammation is important in the development of lymphedema, and also have several translational medications that might be useful, including ketoprofen by the Roxon group and also tacrolimus by the Marara group. To summarize, the fundamental studies on lymphangiogenesis that we and other groups have done have yielded improved understanding of lymphedema. We're starting to develop some potential drug targets that may prevent or mitigate disease. These fall into two classes in my mind. One are the pro-lymphangiogeneic agents. These include VEGF-C gene therapy, which is currently in clinical trial, and also 9-cis-retinoic acid, also called LE&RN, which is already FDA approved for other indications, but we would pursue an indication for 9-cis-retinoic acid for lymphedema. The second class are the anti-inflammatories, which I didn't speak too much about, but some of them include ketoprofen, tacrolimus, and others. It is my opinion that optimally these drugs need to be administered at the time of lymphatic injury or soon after to prevent the formation of lymphedema. However, more translational work is needed, and further basic science will lead to a better understanding of the drugs we're testing, as well as potentially new options in the future. I'd like to acknowledge some of the funding sources that made this work possible. In conclusion, I'd like to thank you all very much for your attention. Great, so one question I saw was whether or not VEGF-C could potentially be used for patients with primary lymphedema. And I think this is a good question. Primary lymphedema, at least based on some of our early experience and those of people around the country and world, is different from surgically induced or surgical lymphedema. And it seems that they don't necessarily respond as well to some of the surgical modalities we're doing. And that might be because really the pathophysiology is different. The lymphedema has been long-standing if it is something that was congenital. And in order to determine if VEGF-C would be appropriate, a full workup of really the specific lymphatic pathology would be necessary, whether it's an entire limb with no lymphatics anywhere in the dermis or deep lymphatics, or if there was a segment where there was a lymphatic insufficiency that could be bridged. In the latter situation, where there is a discrete lymphatic defect, that might be an opportunity where VEGF-C could be used to regenerate lymphatics. And I think it's a little bit early. Those should be done in a controlled fashion. I think the safety of adenoviral delivered VEGF-C still is being evaluated. I'm very hopeful that it will be effective and safe. And just we'll conclude by saying it's still under study. Hopefully it will be produced in a safe form and dose where it could help people with primary lymphedema. Some of the other questions that I saw come up, one is that it seems that basic research activity related to lymphatics has increased rapidly over the past few years. And I think the question is, why do I think the research area has sort of skyrocketed? It's really exciting, and I'm pleased and happy to be part of it. There's so many hardworking and dedicated and smart people in the lymphedema research field, and I'm glad to at least interact with a lot of them. I think the research has taken off, one, because of awareness and interest groups like LE&RN, for sure. I think understanding that it is a problem is good and good for clinicians, and also as it trickles down to some of the researchers that have more of the molecular techniques to explore this, they'll understand better and understand how people really are impacted, and that will likely drive them to work harder on this very challenging disease. The other thing is some of the tools to explore lymphatic biology have come online more recently. As most of you know, there's arteries, there are veins, and then lymphatics as part of the circulatory system. The lymphatics are actually smaller than artery and veins. They're less predictable, have more variation in anatomy, and so they're hard to localize. Recent discoveries about how to visualize lymphatics in living animals, and also how to capture specific lymphatic cells that can regenerate at some point, have come a long way, and understanding receptors on cells that are specific for lymphatic endothelial cells have been important. So all these scientific reagents have come online to allow us to identify lymphatic progenitor cells specifically, and also we've built animal models to study this in a more robust fashion. So just understanding that lymphatics are certainly different from blood and vein endothelial cells has been important, and now that we can distinguish the lymphatics from the other circulatory vessels, it's allowed us to understand their biology a lot better. So I'm looking here at some other questions. Let's see. A recent one was, let's see, Carson, simply do you recommend patients take vitamin A with lymphedema? And that's a good question. And I gave a similar lecture recently over the weekend, and another insightful person asked the same question. So retinoic acid pharmacology is complex. There's multiple receptors that retinoic acid can bind to. There's two. One is known as the retinoic acid receptor, or RAR. Another one is called the retinoic X receptor, or RXR. We're still exploring the specificity of 9-cis-retinoic acid, but of course 9-cis-retinoic acid is a vitamin A derivative. My thought is, would high-dose vitamin A do the same thing? The answer is I don't know, but I don't think you could take enough vitamin A to get high enough levels of the downstream products such as 9-cis-retinoic acid, which would have specific effects. Vitamin A is fat soluble, it's stored in the fat. I think if you were to take too much, it might be dangerous. So unfortunately, I think it's unlikely that that would be helpful. However, it hasn't been formally tested by my group, but a very good question. Another question I see, do you think retinoic acid could improve lymphedema that is already established in stage 2 or stage 3 disease? This is from Colleen McGuire. And my thoughts are that probably not. Based on everything we've seen with 9-cis-retinoic acid, is that it's very exciting, but it does require that there is some, it works best when the disease hasn't occurred. So lymphatic injury leads to inflammation, and it also causes fat deposition and fibrosis. 9-cis-retinoic acid is more directed at regenerating lymphatics. And for stage 2 and stage 3 disease, the adipose tissue has already been deposited, the fibrosis has already occurred, and I don't think it would do much to reverse that. So unfortunately, it probably wouldn't be good for that. I think its primary role would be for prevention. There's a thought that it might enhance surgical therapies for lymphedema, such as vascularized lymph node transfer. Since the data out there on lymph node transfer is mixed, sometimes it works great, sometimes it's unclear if it works. I think that 9-cis-retinoic acid as a pro-lymphangiogenic molecule might accelerate lymphangiogenesis in lymph node transfer, and so it may have an adjuvant role there. So I'm looking down to see about other questions. Thank you so much. These are really good questions. Sandy Hogel, how can, as a patient, I learn if a medication or treatment is FDA approved? A good question. Probably the same way I would do it would be to use some of the great search engines like Google. If a drug is out there, they will, in their information packet, indicate their approval status. Also, the FDA.com website should offer that availability. And also, if you're going to consider a treatment, I would certainly consult with a physician that would be prescribing it, since she or he should know about the FDA approval status. Just looking at other questions, here's one earlier, maybe I missed, from Laura Farrell. And the question is, can you comment on any risk of 9-cis-retinoic acid use for patients that might have residual cancer, but still want to use it to improve their lymphedema? And yeah, I think this is one of the advantages of the retinoic acid group as a potential therapeutic modality. It's not a growth factor. It hasn't been associated with promoting cancer cell growth or metastatic spread. It really is a factor that causes existing lymphatic cells to morph into functional lymphatics. So it's really a differentiation factor. The other thing is 9-cis-retinoic acid, its actual FDA approval is to combat Kaposi sarcoma skin cancer. So it's actually, in some ways, a chemotherapeutic that causes that cancer to differentiate and become less cancer-like. So we are formally going to test this by putting 9-cis-retinoic acid adjacent to residual cancer cells in some of our advanced animal models, just to prove it definitively. But based on all data that I know from that's out there from other groups that's published, I would be very surprised if it would be a problem in cancer patients. But to be very sure and provide the most safety data, we're going to test that explicitly. So again, thank you for that question. All right, looks like I got the signal from LE&RN. Again, thanks for tuning in. It's been a great opportunity to share some of my expertise, and thank you for the questions. I look forward to sharing more progress from our group and really translate this to make a real impact in terms of preventing lymphedema and hopefully using some of the retinoic acid therapy or others as an adjuvant to some of the tools we have to make lymphedema better for those that have this very impactful disease. Thank you all, and have a great day.